Welcome to AETCM, the Emergency Medicine channel.
Yeah, please.
47-year-old male patient presented here with a history of sudden onset of head version to left side, followed by a tonic-clonic movements of left upper limb, followed by similar movements in all the limbs lasting for 2 minutes, followed by a postictal confusion. Patient arrived at our ER. On initial 10-second assessment, patient was unaware and unresponsive. On primary survey, airway, there is no secretions, no gurgling or no hoarseness of voice, no stridor. Breathing, respiratory rate is 20 per minute, saturation 96% in room air, air entry bilaterally equal, circulation, heart rate is 88, BP was 140/90. During that time, we keep a 2 large IV bore cannula. Disability, GCS is E1, V2, M5. Pupils bilaterally equal reacted to light, preference to left side gaze. Now GRBS is 144. Next.
What?
Left side gaze.
Gaze preference was there.
Gaze preference. GRBS 144. Exposure was febrile.
So one important thing I would like to know at this point is what is the time gap between the event and presentation?
2 hour ER also.
When the event has happened, how long has it passed?
20 minutes they arrived at
approximately within 20 minutes the patient has come here. So from the history it looks like most likely the patient have had something equivalent to seizures and has been brought in with 20 minutes after the episode, and even after that he remains in a postictal but slightly unresponsive state with suspected some kind of gaze preferences also. Okay, fine. And your basic hemodynamic assessment at that point is within normal limits. And that's it.
Airway also maintained, no secretions, nothing.
Fair enough. Yeah.
Adjunct to primary survey, ABG, pH is 7.297, PCO2 is 52.5, bicarbonate is 24.9, lactate is 3.7, potassium 4, sodium is 137, calcium is 1.17. ABG reports.
Okay, so what's your take at this point?
There is some respiratory acidosis.
It's an ABG or a BBG?
ABG, sir.
It was an ABG. Okay.
PCO2 52 and pH is 7.297. Bicarbonate is 24.9. After that,
what's is this a usual pattern you see in a suspected postictal patient, or is it looking like something slightly different?
Postictal phase, if there is tongue fold or anything is there, there is some CO2 retention will be there.
But what's the most common blood gas abnormality you are going to see?
Lactic acidosis.
Why lactic acidosis? Does all seizure have lactic acidosis? Only if the patient have had tonic-clonic movements, you are expecting a lactic acidosis. Okay, and here even though lactates are slightly elevated, it is not very profound. But are you going to be bothered if the PCO2 is going up?
Then I really going to maintain because patient is unresponsive.
I'll be more concerned if it is showing respiratory acidosis than lactic acidosis. Because probably the patient there's a possibility of the patient being in a non-convulsive status or something, going into impending respiratory failure. So a raised PCO2 in a postictal kind of state is more concerning than a pure lactic acidosis. Okay, fine. And what else you are looking at the blood gas? One important thing will be?
Basically, in our blood gas, we first look of GRBS and any electrolyte imbalance.
Yeah, good. So sugars were fine here.
Sugars were fine, and they look for hyponatremia, hypernatremia, hypokalemia, then other is hypomagnesemia, hypophosphatemia. These are the electrolyte imbalance and metabolic causes.
So we'll come to the causes in due course. So here the electrolytes are fine and blood gas also, nothing to intervene at this point. Okay, continue. So
then we take an ECG to rule out any arrhythmias.
Have you put the cannulas by now?
Yes, sir. In circulation part 2 cannula is put.
Fine.
During this examination, patient went into again seizure episode lasting for less than 1 minute, with starting with the left upper limb, then it is spread to all over the body with a tonic-clonic.
So what does that indicate? So now you know the clear-cut pattern of seizures here, right? It is starting off as a focal kind of
Focal kind of
seizure
Then it will
involving only one side, then progressing into a generalized kind of
Generalized
seizure, right? Okay. So what are the different types of seizures, if you want to just mention at this point?
There is focal seizures and generalized seizure. Focal seizures with intact awareness is
What do you mean by focal?
focal is only one part of the body is affecting
No, it is one part of the brain.
brain.
So basically, a specific area in a single hemisphere of the brain is involved is called as focal seizures. When both hemispheres are involved, then you usually consider it as generalized seizures. Okay, right.
In focal seizure, when patient is aware of the seizure with intact consciousness,
Yeah.
that is a simple partial seizure.
Yeah, that is focal seizures with intact awareness, and the other will be focal seizures without awareness. Okay,
That
fine.
is
Fair enough.
compressed partial seizure.
Yeah.
Then generalized seizure, tonic-clonic generalized seizure, and tonic seizure. Tonic seizure means patient in abnormal posturing of tonic posturing. Then clonic seizure is jerky clonic rhythmic movements. Other seizure is atonic seizure with loss of power of tone of the part.
Okay, drop seizures. Okay, just coming back to focal seizures. Always remember that it need not be always a tonic-clonic movement or a involuntary movement which can be present. No? Depending upon the site where the foci is there, the symptoms will be according to that, right? If you are having a motor cortex, definitely you are going to expect a jerky movement kind of thing. Okay. If it is in frontal area, probably just aphasia. Okay. There can be repetitive movements in something else. Okay. So depending upon what area of the brain is involved, the presentation will be like that. Occipital area, probably the only eye findings might be there. Okay. So that will also fall into focal seizures. Okay. Fine. So now, from the looks of it, here it started on a
Left upper.
more like a focal kind of probable focal seizures moving into generalized is our assumption at this point. Okay.
Then we kept the patient in a left lateral position immediately. Then we keep in oxygen face mask with 5 liter O2 to maintain the saturation. Also, there is frothing is there, so the suction was done for that patient. Followed by we start with in first line agent like.
Okay. Before that, anything else in the first aid? So you told about left lateral position. In lateral position is okay, but usually we have this preference towards left lateral position, citing anatomical reasons. And anything else at that point? What is your thoughts about putting an airway at this point? Oral airway. Basically, if you can put an oral airway, you can prevent tongue bite, no?
That is before we can do. Patient is clenching tooth, then it is not able
Exactly.
to.
Never attempt for putting up an oral airway while the patient is having active seizures.
Otherwise, we can use
Yeah.
bite.
Yeah, but those things won't help. When the patient is having an active seizure, those kind of attempts need not be made. But in nasopharyngeal airway, probably yes. If you're having difficulty in suctioning and things like that, even during the seizure, probably putting in a nasal pharyngeal airway to facilitate suctioning and also to facilitate the delivery of better oxygen. So nasopharyngeal airway, yes. Oropharyngeal airway, never attempt in a patient with active seizing. And you have put the patient on lateral position. You are already you have 2 lines. Assuming that you don't have any access.
Then we can give IM. We can midazolam. We can give IM also. Intranasally we can give.
What do you prefer? You have options of all 3 with you. You have IM, intranasal, buccal, rectal. Any mucosal thing has a faster absorption than muscle. So if you have oral or nasal kind of thing, always prefer that for the rapidity of action. Okay, fine. Any other route other than IV, oral, mucosal, anything else? Intraosseous. Okay, especially in pediatric group. Okay, fine. And all these drugs can be, whatever antibiotics we are using, most of it can be given through intraosseous route. Okay. So that is with the initial thing. You have put the patient on oxygen also, and now we are going to give the first drug. Okay, continue.
Then we give the first line benzodiazepines. Like
Okay, what are the options available as first drug?
First drug is benzodiazepine is preferred, like midazolam,
Okay.
lorazepam, and diazepam.
Okay.
Midazolam is faster acting than short acting and fast acting lorazepam. And midazolam given dose is 0.2 mg per kg. That maximum dose is 10 mg. Lorazepam is
IM dose?
IM and IV 0.2
Say,
mg per kg.
okay. IM also usually we give 10 mg only.
10
Fine.
mg. Lorazepam is 0.05 mg to 0.05 to 0.1 mg per kg.
0.052, okay.
0.05 to 0.1 mg per kg. Maximum dose is 4 mg is the dose. Then Diazepam is
And technically you have to give lorazepam little slowly. 2 mg over a minute is the recommended way it is given. Okay, usually we give 4 mg. Fine. Then diazepam also you told. Okay, here continue with the current case. We'll come back to it.
Then we give midazolam. After that we give loading dose of Livipil
Okay.
to prevent the seizure. We can
Okay. So here initially you gave lorazepam. By that time what happened?
patient when
Seizure had subsided. Okay. So here we don't know about the definitive history of the patient. Probably we are assuming it as a new episode of seizure, and we have given the first dose of benzodiazepine. Definitely yes, because history was there, and now a witnessed seizure has also happened. So there is no question of waiting in this patient. Definitely we are going to give benzodiazepine. So after benzodiazepine, probably by that time the seizure has subsided, but you are deciding to go ahead with a non-benzodiazepine anti-epileptic, right? So what are the options available at that point as a non-benzodiazepine anti-epileptic first-line drug?
We have phenytoin, phosphonitoin, levetiracetam. In phenytoin, it is to 15 to 20 mg per kg per dose.
15 to 20
mg per kg. And it is we can give it slowly. Means 50 mg per minute is the infusion dose. Then phosphonitoin is a prodrug of phenytoin. Its also dose is 15 to 20 mg per kg. Difference it is faster acting and it is given fastly. Means 150 mg per minute it can give.
Good.
Then it is next is levetiracetam. Levetiracetam is 40 to 60 mg per kg. Maximum dose is
Around 4.5 grams. Yeah. So that also you can give within 30 minutes kind of infusion. Okay. And so you told about levetiracetam, you told about phenytoin bar phosphonitoin and sodium valproate. Sodium valproate is also similar dose, 20 mg per kg kind of dose. Okay. So the question comes here is there any preference of one over the other as a first line?
First line, it is better to go with phosphonitoin or levetiracetam. Phenytoin is cheaper, but it is more time to get to action, and also it is slowly we can give.
So suppose you have only phenytoin. Huh? Let's assume. What is a major problem with phenytoin? Okay. One key thing is that you cannot give phenytoin and midazolam in the same line. The rest drug precipitation can happen. Okay. Phosphonitoin you can give. Even with dextrose, phenytoin cannot be given because of precipitation. So that is one thing. It does not mean that same IV cannula you cannot give, but same line you cannot, like infusion if it is going, you cannot use the same cannula for giving phenytoin. Okay. So most of the time in our practice we have moved on to levetiracetam as the first line. Now there comes specific scenarios. If the patient is already on phenytoin, you are seeing a drug sheet and you are saying that the patient is on phenytoin, what will you give?
Phenytoin is only double the dose of patient.
Usually we go for a half loading kind of a dose. So half of the loading dose is what if the patient is already on. But again the problem is if the patient is on a stiff dose of phenytoin, don't always assume that you have to repeat the same drug. Okay. Most of the time the phenytoin levels will be adequate. If the patient is on a chronic phenytoin thing with adequate dosing, then probably phenytoin may not be the right thing. You can go for a non-phenytoin as a first loading. Same thing with other drugs also. If they are already on a very high dose of the same drug, probably there is no point in giving the same drug. Levetiracetam patient is taking 500 mg BD. Yes, definitely you are justified in giving a loading of levetiracetam itself. Because already you are on a very high dose of the same drug. The concept is, we are assuming that that is in the therapeutic range. Right? If a drug which is already in therapeutic range, there is no point in giving the same drug. That is the basic concept.
Patient was on levetiracetam, we can...
If it is on a very small dose kind of thing, it is not in the max dose. Like patient is not on 4 grams of levetiracetam per day. Definitely you are justified in giving levetiracetam itself. Okay. Remember this concept, that's all. Okay. Right. So that is with the first line kind of drug. You continue with the case. We'll come back.
Adjuncts Then
So you gave for this patient levetiracetam.
levetiracetam
You gave. Okay.
prevent the seizure. Levetiracetam. Then on secondary assessment.
Okay. After levetiracetam, what happened? You just continue with the case. It's okay.
Then we plan for imaging.
Okay. So probably the patient had no more further episodes. Say levetiracetam was given. After 30 minutes, you are reassessing the patient. What is happening now?
Seizure was subsided. Patient in post-ictal phase. Unresponsive in post-ictal phase. Then we plan for any imaging to.
Okay. What exactly you want to describe the post-ictal phase? Is he like very comatose, non-responsive, or minimal movement to painful stimuli? What exactly was it?
Movements to painful stimulus is there. Even V3 means abnormal sounds he is making while we give painful stimulation, and patient was locating the pain sensation M5.
Because I'll be more concerned if the patient is still having gaze preference and all. Okay. Because at this point, if the patient is in a non-convulsive kind of thing, we might be missing it with a post-ictal state. I'd be happy if the patient is little restless and moving around. Probably I'll be more okay than a patient who is very kind of super calm and with some kind of eye findings. Okay. So post-ictal, if they are slowly recovering from it, from the baseline, moving towards the baseline, then it is okay. Okay. Or else don't always label it as post-ictal. You might miss on a NCS. Okay. So you are now thinking about neuroimaging. Continue.
Secondary assessment.
Yeah, please.
47-year-old male patient with a background history of right vestibular schwannoma. With surgery was done on 2018. With a small residual lesion persisting and a CVA of right MCA territory infarct, hypertensive. Presented with history of sudden onset of head version to left side and tonic-clonic movement of the left upper limb, followed by similar movements in all of the limb lasting for 2 minutes, followed by a forced ictal confusion for 2 to 3 hours. There is no history of tongue bite, frothing, bowel and bladder incontinence, fever, trauma, altered sensorium. There is no history of any alcohol intake, weakness, facial deviation or slurring of speech. Systematic examination, pupil was bilaterally equireactive. There is left preference gaze is there. Moving all 4 limbs after the post-ictal phase, moving all 4 limbs. CNS, cranial nerves are intact, system-wise with normal limits. MRI. Okay. Initially, we take a CT brain plane.
Okay. This patient probably you could have gone for an MRI upfront. So basically, we already have a patient with a past history of intracranial pathology. Right? And your choice of imaging in seizure will depend upon what etiology you are suspecting. Okay. So what are the intracranial pathologies you are going to suspect in a patient coming with seizures?
Seizure with fever histories, there is suspecting of meningitis, encephalitis, brain abscess.
Okay.
If there is no any fever with altered sensorium, if there is no any fever history, then there is brain tumor. Already a background carcinoma is there is suspecting for brain mets, brainstem or CP angle tumors.
Bleeds. Okay. So then intracranial hemorrhages, like your parenchymal hemorrhages, SDS, SAH, all those kind of things. Stroke. Not a very common presentation in acute stroke, but post-stroke, old stroke, scar epilepsy kind of things. Okay. 2 more etiologies at PG level? Brain. CVT. Okay. Cortical vein thrombosis and TRUS. Okay. These 2 things definitely needs to be considered in any adult patient coming with seizures, where definitely if there are other features suggesting that etiology. Okay. So that is with the primary brain pathologies leading to seizures. So here we are suspecting already the patient had a previous brain pathology. So definitely MRI with contrast probably would have been the right choice once we have got the seizure under control. If you are suspecting a bleed or anything like that, then definitely CT or a raised ICP also. Midline shift and all those things you are suspecting, immediate CT is justified. Okay. So we just came to the etiologies, right? We spoke about the primary brain pathologies. So what are non-brain pathology, what else can cause seizures?
Initially start with metabolic
Good.
hypoglycemia,
Good.
hyperglycemia, hypernatremia or hyponatremia.
Mostly it is both hypo, where early it can cause
Hypocalcemia, hypomagnesemia, hypophosphatemia.
calcium.
Hypocalcemia, hypophosphatemia, hypomagnesemia. Other causes are acute alcohol.
In metabolic, you want to add anything more?
Uremic.
Uremic and thyroid.
Thyroid. Other is any drug intake like ecstasy, pills or cocaine or alcohol intake and alcohol withdrawal. Then
Not only alcohol, lot of other withdrawals also.
others like drugs like any tramadol, antibiotics like
Quinolones.
fluoroquinolones, metronidazole, isoniazid, some penicillin derivatives.
Okay.
Then other infection cause meningitis like the
Fair.
stroke.
And trauma.
Trauma.
Okay. Fine. So that is with the etiologies. Now you will come back. This patient probably initial CT was negative and we went ahead with an MRI. Okay.
MRI brain plane showing there is no acute infarct or hemorrhages. Right CP angle lesion remain same in size. Then some old changes also. Sir. Basically, patient diagnosed as a scar epilepsy. Already there is a right MCA infarct, and patient symptoms also start with left upper limb and focal seizure and generalized. So diagnosed as a scar epilepsy because the old lesion is same as size.
Okay. Fine. You want to add on anything at this point? So we spoke about the initial drug of choice. We quickly mentioned about the first agent as non-benzodiazepine anti-epileptic also. So now we will come to a scenario which is more important to us. That is status epilepticus, right? We have a patient who has presented to us, your initial two drugs are not working, patient is continuing to have seizures. Okay. So our concern is a patient who is continuing to have seizures or a patient who is having recurrent seizures without returning to baseline. Those are the two things which will fall into this definition now. Okay, that is one is continuous seizures more than 5 to 15 minutes, definitely yes, or else without returning to baseline sensorium, patient is continuing to have recurrent episodes of seizures, right? Okay, so you have tried your first line, you have tried your second line, it is not working.
Then we can go with infusion with some phenobarbital, arimidazolam or propofol.
So your first line you gave, your second line we told
Antiepileptic syndrome.
that is levetiracetam, fosphenytoin, phenytoin or sodium valproate. So the next will be
Anesthetic.
before midas valproate we told, topiramate, okay, and lacosamide. Lacosamide 200 to 400 mg will be the second line. Okay, these two also doesn't work. That is when we are going towards your anesthetic agents. Okay, what are the indications for intubation in seizures?
To maintain the airway, unprotected unmaintained airway, patient into hypoxemia.
If the patient, because of seizure, patient is going into hypoxemia, for just for protection of airway, fair enough.
Severe respiratory acidosis, PCOS build-up.
Excellent.
And patient was unresponsive. We cannot give NIV. So in that condition, we went to ventilation.
Okay.
Status epilepticus lasting for more than 30 minutes.
That is the important indication, right? If you are not able to take care of the seizures, if the patient is continuing to have seizures for more than 30 minutes, that itself will become an indication to intubate and start on anesthetic infusion. Fine. Then one more. If you want
to do any imaging patient.
Yeah. To facilitate an imaging in a seizure patient, because active seizures you are not able to get the imaging done, right? Okay, so those are the 5 indications. Like coming to the drugs which needs to be used for intubation in a patient whom you are suspecting status.
If there is no hypotension, we can preferably use propofol.
Fair enough.
Propofol causes hypotension, so if there is no any hypotension, we can use propofol.
If it is an institution which is comfortable with propofol, definitely propofol is a good choice. Anything else?
Etomidate or ketamine we can use.
Not ketamine. Ketamine you should not be giving. Active seizures, it is not, because we are going for drugs which have potential anti-epileptic properties. Once we have that, then definitely no point in going with ketamine. No? So propofol and midazolam will remain top in the line. Etomidate, theoretically there is, it decreases the seizure threshold thing, but no, but it's okay to give. So midas, propofol or etomidate will remain your induction agent. Okay. Paralytics?
Coronium.
Why not succinylcholine?
That causes.
Again, it is more of a theoretical kind of aspect where already with seizures you are anticipating probable hyperkalemia because of muscle activity and you don't want scoline to further worsen it. But the advantage with scoline probably is it is short acting compared to your rocuronium or vicuronium, which is going to be a prolonged course of action, prolonged duration. Because what is happening? This is going to mask your seizures at the end of the day. A patient with neuromuscular paralysis, we won't be able to know that the patient is having seizure or not. Right? If you have continuous EEG monitoring, then no issues. So ideally at that point, if the institution has EEG capabilities in a status patient, within the ER itself, you have to start the patient on EEG monitoring, especially when you are intubating the patient. After intubation, it is always better to have the patient monitored under EEG, and EEG guided anti-epileptic titration needs to be done. Okay, so with your paralytics, definitely your other artifacts will subside. The brain activity only will be picked up with the EEG. Got it, no? Okay, so we spoke about the first agent, second agent. Intubation we discussed. Infusion, definitely. Post intubation, we will be starting with most likely midazolam infusion and uptitrating midazolam according to the needs. There are a lot more neuro anti-epileptics available now, with definitely from an ER perspective, we need to know only this much. Beyond that, with the neurologist help, probably neuro anti-epileptics we can always try. And always think about the etiology at this point. Because if the patient is having hyponatremia, there is no point in going upon your conventional anti-epileptics. You have to treat the primary cause which is causing the seizure. So at this point, always search for causes, including your metabolic causes, infective causes, structural causes, and once you identify the cause, you start treating the cause only, you are going to get a control of your seizures. How long are you going to continue anti-epileptics once started?
6 months.
There is no hard and fast rule for that. It again depends upon the etiology. Okay, you are expecting a reversible etiology, then there is no point in continuing epileptics for long. So if you are confident that the trigger factor has been identified and it has been treated, probably a shorter course is justified. Once you establish as an epilepsy, then definitely you need to continue on the anti-epileptic for a longer duration of time. Okay, anything else? Yeah. Anybody else want to add something? No? Okay, right. Thank you.